draft is better than your last draft. Rapping like a vampire wrapped in a black sash, all blood.
Welcome to this informative journal about the appropriate indications for dental floss clip traction-assisted endoscopic submucosal dissection in early gastric cancer. The aim of this study was to clarify the appropriate indications for the dental floss clip traction method in early gastric cancer when endoscopic submucosal dissection is performed by less experienced endoscopists. This figure illustrates the use of DFC traction during ESD. In parts A and B, after circumferential incision, the DFC is attached to the oral side of the resected mucosa. The DFC is a small clip that is used to provide traction during ESD. The clip is attached to the mucosa using a special applicator, and it helps to maintain tension on the tissue, which makes it easier to perform the dissection. In parts C and D, the DFC gives an appropriate tension, ensures a good submucosal view. The DFC provides a stable and controlled traction force that helps to expose the submucosal layer and maintain a clear view of the dissection area. This allows the endoscopist to perform the dissection more safely and accurately, reducing the risk of complications such as perforation or bleeding. To achieve the aim of study, the study analyzed 1,014 consecutive patients who underwent gastric ESD between January 2015 and December 2020 at the Hiroshima University Hospital. Only cases performed by a less experienced endoscopist were included. Less experienced was defined as having less than 40 gastric ESD experiences. The patients were divided into two groups: the DFC group, which included patients who underwent ESD with DFC traction, and the no DFC group, which included patients who underwent ESD without DFC traction. Table 1 presents the baseline characteristics of the patients. The table shows that there were no significant differences between the DFC group and no DFC groups in terms of age, sex, tumor location, tumor size, or histology. Table 2 summarizes the treatment outcomes. The table shows that there were no significant differences between the two groups in terms of procedure time, en-bloc resection rate, complete resection rate, or specimen size. This suggests that the use of DFC traction does not compromise the quality of the resection or increase the risk of complications. Table 3 shows the results of the procedure time according to tumor characteristics. The table indicates that the procedure time was significantly shorter in the DFC group for lesions larger than 20 mm and located in the greater curvature of the upper or middle stomach. Table 4 shows the procedure time for lesions less than 20 mm. For lesions located in the greater curvature of the upper or middle stomach, the DFC group had a significantly shorter procedure time. This result is the same even in lesions larger than 20 mm. Furthermore, DFC group had a significantly shorter procedure time for lesions over 20 mm in the lesser curvature of the stomach. In conclusion, the indications for DFC during gastric ESD by less experienced endoscopists include lesions located in the greater curvature of the upper or middle stomach, and lesions less than 20 mm located in the lesser curvature of the stomach.